From October 10th, any of us who have contracted COVID-19 would likely be able to recover from home.
I know many people still have concerns and anxieties about home recovery. They are fearful of the disease itself. They fret about the risk to the rest of their household. They also worry whether they'll receive adequate care and support at home should they get worse. I understand your anxieties. Let me assure everyone on home recovery that you will get the care and support you need throughout your recovery journey. Earlier, our service delivery fell short, but we have worked hard to fix this and put things right.
As of 14th October, more than 16,000 people are on the home recovery journey. In this episode, I bring 3 experts to answer all your burning questions on the home recovery program. Over the past week, we've gathered questions from viewers. We've had over 30 queries and feedback. Let's take a look at some of them.
My daughter, who's 3, started developing symptoms such as chest pains and fevers, but she wasn't a confirmed case in the system yet. So we ended up getting bounced around from MOH to Certis Cisco to the Teledoc and then back again to MOH.
During my day 6 of isolation, I called the hotline and requested for my medicine to be replenished as I was still having cough and fever, but no one get back to me. How do you intend to improve this communication?
So Adrian, you provide a lot of support to infected patients in the community. Are you still hearing problems about service delays?
Definitely yes. There has been quite a number of people who says that their medications are not delivered on time, they're unable to reach the right person, but frequently what they face is actually difficulties in understanding how the whole process works. So they could be actually calling the wrong parties, like for example the home recovery buddy, when who they need is actually the telemed doctors.
Can you give me some idea how frequent this was?
About 50 to 60% of them can be still quite confused in the whole situation. I mean, it has been simplified, but they are in transitioning to the new protocol. So there's still some stabilizing phase that they need to go through.
Rachel, you're with a telemedicine provider. Have you found it difficult to have enough doctors to support the calls that are coming in?
The challenge that we face right now is the technicality and the know-how of using a telemedicine software. Our own doctors, they are not familiar with using an app, and they do not know how to use various type of apps because various telemedicine providers, they have a different kind of app. So in the end, out of 200 doctors, I have to filter out maybe about 100 of them who is not very tech savvy, and I have to filter another 30 away because they do not want to use WhatsApp to contact the patient.
Payway found it difficult to have a 3-year-old daughter get medical attention. Dinesh, how would you respond?
When we opened up, we expected about 100 to 200 cases per day. We weren't expecting the intensity and the duration, meaning from the time we opened up, we thought we'd have a bit more time, as we have seen from other countries, and as we have studied from the data that we've had. Unfortunately, in our case, perhaps due to the density of the population, because of the fact that many people were moving around, the numbers climbed up a lot more than we anticipated. When we saw the doubling happening at 6 to 8 days, we realized that we had to quickly ramp up our capacities. So we called for volunteers, we had additional call center facilities, and we also activated the SAF. Today, we have about 453 callers at any one point in time who would be able to answer. And we've had an achievement rate of the incoming calls of over 90%.
Right.
So there will be people who will still not be able to get through, but that number will be very, very small moving forward.
There's a lot more manpower on the ground with SAF coming in, but these guys, I imagine many of them will be young, serving their national service, may not be as familiar with everything. So is there a chance people like Payway will call in and he'll say, I'm not sure, can you please call this other number?
They have to go through a rigorous training package. We all must understand this is not their core business, but they have been trained using professionals to be able to answer questions. One of the issues that we started off with was because we were moving to a system where we could direct the calls accordingly. But unfortunately, we weren't able to do that fast enough. Today, that system is already in place, and we have tweaked it even further. So if you call in, you have a menu of options, and based on that menu, you go to the person who you need to talk to.
I think the crux of the problem is that when you go to a doctor, when you go to a regional swab center for a swab, I expect the doctor to explain to me, if my swab is positive, what is the next action plan for me? But instead of getting a next action plan, our patients is actually getting SMS. So it's a bit haphazard. I personally feel that the first touch point to break the bad news to our patients is actually should be the doctors. When we convey to them, okay, this is positive, you don't have to be worried. Next 10 days, you just isolate yourself. You won't be so infectious at the end of 10 days. And they are very thankful. And that would be the last call they need to make because of the reassurance from the doctors. I think that will actually solve a lot of phone call issues.
I think most importantly, we follow up with the call as quickly as we can. And that has been one of the new protocols that we've put in place. So within 24 hours, you should be hearing from an MOH officer and or a telemedicine provider.
Okay.
So that will help to assure.
Has there been a case of conflicting instructions being given to people on the ground so that they're not quite sure how to react?
There were cases that we have discovered where there were inconsistencies in the way we have approached our policies, and that was one of the main reasons why we've decided to streamline policies to keep it as simple as we can. And I think that simplicity helps to communicate and helps the public to understand what they can and cannot do.
I completed my isolation order on 3rd of October. However, my Trace Together status still indicates not clear. What should I do?
Happy to report that from the 8th of October, a few days ago, the TT app is aligned to your vaccination status if you are infected. So if you are given a test and you're confirmed to be PCR positive, if you're vaccinated, after 10 days, automatically it turns back on again. And 14 days for unvaccinated. So that's been resolved.
But majority of the situation on the ground is that the family that got diagnosed with COVID positive in the initial days didn't declare the rest of the family. So they submitted the dates on a different time, which essentially the family may not be discharged at the same time.
I'm sure we will be facing such issues in the future where wrong data is added in, unfortunately. Telephone numbers can be wrong, addresses could be written wrongly. This has a profound issue back end when you've got thousands of cases to deal with. That exacerbated some of our delays initially. But I understand that when people are unwell and they're not in the best frame of mind, errors do occur.
I'm tested positive COVID for 4 days already. I'm living in a one-room flat with one bathroom. Why am I put on home recovery when my house is not suitable?
Some households are just really small, there's no space. What should people like Nico do? And welcome back. We've been talking about what it takes to recover from COVID-19 at home. We've got some questions from viewers regarding just how safe it really is to do that.
I'm tested positive COVID for 4 days already. I'm living in a one-room flat with one bathroom. Staying with my mother, she's 64 this year. And why am I put on home recovery when my house is not suitable?
Some households are just really small, there's no space. What should people like Nico do?
Most of us do not have our own ensuite bathroom. From my personal experience, only a small fraction, I would say 1/4 will have their own personal bathroom or toilet. But it is fine for the family members to share the toilet as long as there's a 30 minutes gap in between use, and the COVID positive patient has to do a proper wipe down. It means that they have to close the toilet seat before they flush the toilet, and they have to ventilate the toilet for 30 minutes. Studies have shown that most of the transmission happen during mask down activities. It's not really when they talk to each other or the usage of toilet. So as long as the COVID positive patient has to remain in the room when they have their meal, I think it's fine.
I think what the doctors has mentioned is, I'll say from the perspective from a doctor, because they are unable to understand how the processes is like. But for a typical Singaporean, they will say, hey, you know what, my mother is too old to clean the toilet for us to use. There's a situation whereby, how do I clean it, which makes it the most effective? How do I know that this is really safe? And they spend the rest of the time thinking about how to clean the toilet. They always focus while thinking about how can I arrange something else for my family, including getting them to the hotel, the CCF, and so on.
We know that a majority of Singaporeans are able to home recover safely at home. Some of us may not be able to do so, as the video has indicated. And for people in such conditions, we will bring them out to a government facility for them to recover in.
Okay.
So that is a person who's living in a one-room flat, as was in this case. He would be, and he should be, in a community isolation facility.
But not all of them are. So how risky is it for them to continue to live in the same space?
If you have to be isolated at home and you don't have an ensuite toilet, it's important for us to be taking the necessary precautions. The key point is this: COVID is a disease that spreads infectiously, but only in certain settings does it spread more than other settings, mask off and so forth. And if protections and precautions are taken, the level of household spread that we are seeing is less than 10% as compared to what we are seeing across other settings as well.
Tim had written into our CNA Insider Instagram page to ask, what about people living with unvaccinated elderly and children, for example?
Before we put the person on home recovery, we have to assess the home condition, whether the household members, any of them are more than 80 years old, whether any of the household members are not vaccinated, and whether any of the household member is less than 1 year old. So if we know that the household members are actually vaccinated, assuming they're vaccinated, the risk of getting severe disease is actually reduced.
It's not about whether they're going to get severe reactions to the COVID, but it's more about the family passing the COVID virus to their family, that they feel responsible, they feel guilty. What they wanted to prevent is that I don't want my family to get COVID. I know they won't get into critical illnesses, but I don't want to get COVID is the main statement that we hear on the ground. So what if we can prevent serious complications? It still means that I spread the disease to my family and I'm responsible for it. And that guilt causes a lot of mental health issues among people.
Let's look at it in another perspective. What if I tell you that it's not COVID, it is a flu? Okay, so when we get flu, there's a tendency for us to actually pass this flu to our family members. Are we as anxious if we are talking about flu?
Yeah, but Rachel, right now the fear is not of the flu virus, it's of COVID. This real fear of COVID, whether it's severe or not, they don't want to be infected. At the end of the day, are you actually telling all of us, don't be afraid of COVID?
The strategy of wanting to prevent it at all costs because of the fact that it could be life-threatening is no longer the case. And I think we should be happy with that. The fact that we have a high level of percentage of vaccinations, the fact that we have booster vaccinations, and I'm watching the booster numbers daily, and it's very encouraging that the elderly are taking up boosters very significantly. Boosters allow you to have a 10 times higher chance of not even getting infected in the first place.
Okay.
So, message to the elderly, get vaccinated, get boosted. So when you have unvaccinated people around, that's when the guilt comes in, isn't it?
But even if we do get infected, the message is also don't be so fearful of it, because most of the time it will not result in severe illness, right?
I think we need to demystify COVID and to make it something that we are able to combat. Because this is a virus, it's like an enemy. We have to find a way to overcome this enemy and not be paralyzed by fear.
Let's take a look at another question.
My brother actually has some medical condition. He was diagnosed of having a mild stroke 2 months ago. Because of my brother's condition and home environment, why actually he's not been transferred?
I wouldn't allow this individual to recover from home. If I were the doctor, I work very closely with ministry, I'll definitely speak to the team to get him transferred to a care facility.
The way we do it right now is that after we have identified that the person may have certain needs, they get partnered with a telemedicine provider. The doctor's call is the final call. If we find that the doctor says that this person shouldn't be at home and we should pull him out, we should do so. And we will do so. In this particular case, if he had multiple issues, he was a very old patient, vaccinated or otherwise, above the age of 80, we would have pulled him out anyway. So I suspect we have to probably figure out what exactly the details of this case.
Okay, so Adrian, how concerned are you about many of the seniors who are recovering at home?
What matters the most to the seniors is actually communications. Am I going through this correctly? I'm having some briefing difficulties. Am I right to call someone? And who should I call? And if this number doesn't work, should I call the other number? If they couldn't still get through to talk to anyone, or if the agent that spoke to them didn't give them a satisfying answer, satisfying as in something that they expected, that actually gets them into a panic mode. They start to think that, oh, the government is leaving me to die, Very negative thoughts starts to flow into them. They may even sometimes say that I'm just going to leave house, I don't care about the COVID situations or what the order that I received and so on.
So there's so much frustration that they kind of just give up altogether.
So I think there's a social element to it as well. It shouldn't be one that's just a simple phone call and that's it, the end of story. So increasingly what we are partnering with the People's Association, for example, is for us to reach out to these individuals to try to deliver something to them, be it certain, bare essentials that they might need while they're on home recovery, ART test kits if that's what they need, and if not for anything else, a simple card to say, recover well, we are all behind you. We are starting to roll this out. In fact, many constituencies have already started this.
I want to know, how are we ensuring that people who are put on home recovery really stay at home?
This is all yours, Dinesh.
If you are a COVID positive patient, you are subject to the Infectious Disease Act, for which if you leave your premise without authority, you can be prosecuted. But I think more importantly, we need to adapt the social dimension to this, to tell people that we will all be meeting COVID in some shape or form as we progress from here. They might need support, they might need help. What can we all do?
Right.
Rather than to just shun them and put them in a box.
Singapore is expected to hit over 5,000 new daily cases with over 70% of the patients put on home recovery. How prepared are we to manage that caseload? Welcome back. Now, Singapore is expected to hit over 5,000 new daily cases with over 70% of the patients put on home recovery. So that means a lot more people, more than 19,000 who have been put on board the home recovery programs. How prepared are we to manage that caseload?
If you have 5,000 cases per day, that would mean you would have 50,000 in our system if you have 10 days, assuming it's 5,000 for each of the 10 days. If you have a household of 5 members per household, that number balloons to 250,000. So it's not a very small number, and it's not a number that our healthcare system in itself is able to deal with. Therefore, home recovery will become a default. We have the COVID-19 treatment facility, so that we are also ramping up. We also have the community isolation facilities. I can't isolate at home, so am I able to isolate in a government facility? We have sufficient hotels to do that function as well.
So are all these facilities already in place, and are we prepared and ready to face these numbers?
We are fairly confident that by the end of next week, we should be ready to accept 5,000 cases.
Some of our viewers have sent in suggestions on how we might actually do this.
There are 6 in my household and everybody tested positive. Why are we not managed as an address, but instead managed as 6 different cases? So that creates a lot of duplication of work.
So that seems like a pretty good suggestion. Why not manage the cases by household rather than individuals?
Indeed, that's indeed what we are doing. Moving forward, we are looking at it as a household entity, meaning people who are infected as well as the households of those who are infected. It is the person who's infected is supposed to indicate to us who exactly is in the household. So once that information is passed over to us, we look at it as an entire family unit. No longer as whether you are quarantined or you are a COVID positive patient, you are a family, and we will address it as a family. Telemedicine providers will be not just for the COVID positive patients, but if the other household patients are indeed exhibiting any illnesses as well, telemedicine is available, and so too community services.
I want to know if there are any assistance in terms of daily necessities extended to low-income families who are on home recovery.
My mom has to go for PCR tests or answer calls from MOH or CERTIS. She can't really speak English and she can't write English as well.
I belong to an organization called SG Assist. With this platform, a lot of families could actually request for volunteers to help them to get groceries, get food. But on the ground, there's many community groups. Anyone like her actually wanted to find out more leads to how they can actually get all this information and resources. They can always look out for the nearby social services agencies. We are receiving over 100 calls to up to 300 calls a day, supporting communities that needed help, that is not currently supported, or kind of like get lost in the whole journey. So we have Chinese-speaking agents, Malay-speaking agents, some of them are volunteers, and we're helping these people to navigate this whole care journey adequately.
And Rachel, what about your doctors? Are they fluent in different languages as well?
Most of our doctors are able to converse fluently in Chinese and English. And we do have a fair bit of doctors who speak Tamil, not many. When we actually look at the patient, we will also assess the family members as well. And that is how we actually pick up whether this family is able to cope with their daily necessities. We don't just look at them and see whether they have medical needs. We also assess their social needs as well.
Adrian, what do you think are still the gaps that are missing in this home recovery program?
Basically, still communication. Even with the ART kit, with a very fully well-written picture guide to teach them how to do ART self-test, many seniors, I would say, even for those that is between 45 to 55, they still couldn't do the swab on their own. I guess it's not just about communication, but also how can we actually ensure that this communication flow through. That there are also people who are not exactly digitally able to receive all this information. There are seniors who only have a typical phone that is not smartphone. So they can't even know their trace together. That causes a gap where they are literally don't know what to do. And that's where they start crying. They say that, what am I going to do? Am I going to die alone at home? This is actually a gap that needs to be addressed gradually.
There was a point that Adrian mentioned which kind of resonated with me, which is the fact that if there are people who are out there and they need care, they may not necessarily be care that's related to COVID. I need to buy groceries, I might need to go for my dialysis and so forth. Our call agents will take such calls too. If I need to bring a person who's in home recovery for a dialysis session, that has been done before. But I think he's referring to a very important point of other issues that are not medical. And how do we then ensure that there's that touch point? Volunteer groups will have a part to play, community groups will have a part to play, the family will have a part to play.
In fact, each and every one of us having a part to play as well. So on that note, I'll have to say goodbye. Thank you all so much for joining us. Those of you at home, we hope we've been able to answer some of the queries you have about the home recovery program. Till then, stay safe, and I'll see you again soon.